cyst. The case will be presented by Dr. Anuradha Maji, who is a third-year resident at SSKM Hospital, IPGMR. And with me will be today Professor Vinu Basu, Professor and Head at IPGMR SSKM Hospital. So Anuradha, you can share your screen. Wait, at the end of history, we will have some discussion and then proceed into examination. Anuradha, you share your screen and start presenting.
Okay, sir. Sir, good morning, sir. Today,
Yes.
my case presentation is of a obstructive jaundice due to choledochal cyst. Patient particulars were Mr. A, 25 years of male, school teacher by occupation, hailing from Bandel. He presented with a complaint of yellowing of urine and eyes for the past 1 year, and also right upper abdomen pain for the past 1 year. Apparently, 1 year ago, patient started noticing dark yellow coloration of the urine, immediately, which followed by yellowing of the eyes within few days, which subsided spontaneously in few weeks and recurred twice over the past 1 year. He also started experiencing intermittent episodes of mild intensity, dull aching, pain in the right upper abdomen during the episodes of jaundice, the pain was not related to food intake, and it was relieved or partially controlled with pain medications. It was associated with nausea, but there was no history of vomiting. There was no history of fever. There was no history of any pruritus or clay-colored stools, and there was no history of any dyspepsia. There is no history of any comorbidities and no history of any similar illness in the childhood. And there's no history of any previous surgeries. Personal history, he is unmarried, takes mixed diet. There's no history of any addictions, allergies, or any chronic medication use. Sleep and appetite are preserved. The bowel and bladder habits are within normal limits. There is only a family history of gallstone disease of his father, and who got operated at his 68 years of age. Treatment history, he underwent abdominal ultrasound scan and MRCP, and tablet ursodeoxycholic acid was started 1 week ago. Presentation. So this is the history.
Okay, wait. Go back to the history of presenting.
Yes.
Yes. Dr. Basu, you have something?
Yes, as per conclusion that what can be the cause of this thing. Anuradha, up to this point, what is your provisional diagnosis?
It is a case of jaundice with pain abdomen. It can be a case of polylithiasis, or it can be with features with episodes of acute cholecystitis, or it can be a case of choledochal lithiasis. It can be a case of a choledochal lithiasis with a choledochal cyst, or it can be a case of medical jaundice also, only by history. Non-obstructive jaundice.
Why you are thinking of medical jaundice in this case?
Because the patient is having intermittent episodes of yellowing of eyes and urine, but apart from that, he did not have any history of pruritus or clay-colored stools. Features of obstructive jaundice were not there.
Okay. So the history did not suggest of the obstructive jaundice.
No.
Right. So what is your clinical? Yes.
No, but
yes,
Anuradha, I am not happy with just two paragraphs of history of illness. You see, this is a case of jaundice. Don't get biased at the beginning. What is the type of jaundice and cause of jaundice? You should give more clarity in this diagnosis, because when the patient has got yellowish of the coloration of eyes and urine, To diagnose medical jaundice, one has to find out whether the patient has got any prodromal symptoms preceding the onset of jaundice. You see, patient having viral hepatitis will have malaise, body ache, severe loss of appetite, sometimes skin rash. So, if you can say specifically that patient does not have any prodromal symptom preceding the onset of jaundice, that exclude a possibility of viral hepatitis. That is one. Second is, he have given this jaundice subsided for a few weeks and then recurred twice. So subsequently also, when the jaundice came up, was it same as had happened in the first episode? So that will indicate that the same cause is causing jaundice. Next is, you talked about the pain.
It was a...
And can this still be obstructive jaundice without patient passing clay color stool?
It can still be an obstructive jaundice if the obstruction is not complete, which does not lead to complete obstruction of the bile flow into the intestine.
Yeah. So simply absence of clay color stool does not exclude obstructive jaundice. Now come to the other points. Patient having jaundice, even if it's 25 years, we should go through the other GI symptoms. This can be a chronic liver disease.
Yes, sir.
So you should exclude whether the patient has got any episode of hematemesis, melena. What about his bowel habit, his appetite? Everything should come. You see, history of present illness is not just getting biased with the diagnosis. So you have to write the other symptoms, which may be even negative symptoms. He has normal appetite, he has no loss of weight, his bowel habit is normal. So that excludes some other causes for the jaundice.
Yes, sir. Sir, sleep and appetite are preserved, and bowel bladder habits are completely
I agree. You have gone to the personal history, but what I'm saying is a GI case. So in GI case, all these history should come under the purview of history-present illness. Okay, Dr. Basu.
Yes. So, you should follow the instruction, because when a GI case is presented, see all the negative and positive symptoms should be noted. This is good, important thing. And next is going to clinical. What is your clinical examination finding now? See.
So on physical examination and general survey, patient was alert and cooperative. He was moderately built and nourished. His vitals were stable, and he was mildly icteric. There was no pallor, lymphadenopathy or pedal edema. On abdominal examination, abdomen was normally scaphoid and umbilicus was central. There was no local rise of temperature. Abdomen was soft, non-tender, and there was no hepatosplenomegaly. Hernial sites were free, and external genitalia was within normal limits. And there was no shifting dullness. On the digital rectal examination, normal stool staining was present. And the rest of the system examinations were also normal.
So basically, your clinical examination does not indicate any disease, or rather any finding, positive
only
finding.
Mild icterus, sir. Yes, sir.
Mild icterus. Mild icterus. Yes. So, how to proceed next?
So next we have investigations were done in this patient.
Even if you cannot have some definite diagnosis, we should have some thought of probable diagnosis in this patient. So with what you will proceed? What is in your mind? 25 years, gentleman presenting with 3 pieces of jaundice, pain which are dull, aching, and not like colic.
Yes, sir. Sir, I have 2 differential diagnoses in mind. It can be a case of choledochal lithiasis. It can be a case of a choledochal cyst with a choledochal lithiasis.
You mean a primary choledochal lithiasis, or patient might have stone disease along with choledochal lithiasis?
Stone disease is also a possibility. He can also have a cholelithiasis with a choledochal lithiasis.
Yes, this patient has symptoms suggestive of or finding of hemolytic anemias.
I cannot follow Professor Shah, that what do you mean by primary choledocholitis here?
Not here. What I'm saying is, if the patient has background of hemolytic anemia, like patient has hepatosplenomegaly, patient has episodes of jaundice from childhood, so this can be a background of hemolytic anemia, which can cause a primary CBD stone.
This should not be mistaken by anybody. The primary CBD stone or primary choledocholitis by definition should be the CBD stone in which patient having no gallbladder or gallbladder remnant for at least 2 years. This is standardized definition. So even if the patient having this thing hemolytic anemia and all those things, if the patient gallbladder is present, we cannot say it is a primary. Always you have to say secondary stone. This is by definition.
Okay, I'll check.
Okay, Anuradha.
Yes, sir.
So, how will you proceed?
Sir, since
why
the patient is having...
Just a minute. Why you are uttering choledochal cyst here, clinically? Why? I agree with you, acute cholecystitis with jaundice or the choledocholitis, but how can you clinically say that it is a choledochal cyst?
Sir, clinically, I cannot say.
No, you cannot write also. You can write maybe possibility choledochal cyst or malignancy or anything.
Yes, sir.
What is the classic presentation of choledochal cyst? Anuradha? What is the classic triad of?
Classical triad will be intermittent pain, jaundice, and lump palpable in the right upper abdomen.
Yeah. So this patient does not have a lump?
No, sir. No lump palpable.
Actually, Anuradha presenting in adult patient, the adult patient have very rarely got a lump.
Yes, sir.
So case summary,
okay,
yes,
so
read out.
Summary, a 25-year-old male presented with complaints of recurrent episodes of jaundice and mild intermittent dull aching vague upper abdomen pain for the past 1 year. There's no history of fever, vomiting, dyspepsia, or any history suggested of pruritus or clay-colored stools. There's no history of any addictions, comorbidities, or any chronic medication use. On examination, he is mildly icteric. Abdomen is soft and non-tender, and another system examinations are within normal limits. Sir, coming to differential diagnosis, it can be a case of cholecystitis with acute cholelithiasis with acute cholecystitis, episodes of acute cholecystitis, or it can be a case of choledocholitis. So first of all, since he is having icterus, we'll go for blood investigation.
Wait for the investigation. No, Anuradha, does this patient also fits in with a first diagnosis of acute cholecystitis with cholelithiasis? Do you think this pain is classic of acute gallstone disease?
No, sir. This history is not even classic. Yes, sir.
Yes. So the patient with gallstone disease will have a classic attack of biliary colic. So this patient does not have episodes of pain. So that is also difficult to put a diagnosis of acute cholecystitis on the background of just pain character and no fever. Okay.
Yes, sir.
So this can happen. In that case, you have to keep it open. That is difficult to give a clinical diagnosis. Okay.
So
sir, don't
first
give the values.
Investigation that I... Yes, sir.
Don't give the values. We'll just discuss what will you do.
Okay. Okay, sir. Okay, sir. So first we'll go for an ultrasound scan of the abdomen.
No, first we
upper abdomen or the whole abdomen.
You have mentioned
LFT again.
Yes.
Liver function test will show whether it's a conjugated hyperbilirubinemia or unconjugated. So we'll come to the conclusion whether it's obstructive jaundice. Along with serum ALP, if it is raised, that will be more suggestive of obstructive jaundice with a normal AST ALT levels. And After that, we'll go for an ultrasound scan of the abdomen, which will show if there is any calculus in gallbladder or CVD, or if there is any dilatation. And definitively, we can go for MRCP for diagnostic as a diagnostic investigation.
First is ultrasound, you said, na?
Yes, sir.
So what are the things in ultrasound you look for in this patient?
In this patient, we'll definitely look for a gallbladder calculus.
Yes.
And we'll also look for whether there's a CBD calculus is there or not, any CBD wall thickening is there or not, any distal stricture of the CBD, or any filling defect is there or not, or a dilatation of the CBD is there or not.
What
any
about
saculations?
IHBR?
Yes, sir. Also the intrahepatic biliary radicals also to see whether they are dilated or not. In type 3 or 5 choledochal cyst,
what finding in ultrasound will raise suspicion of choledochal cyst? What finding in ultrasound will raise suspicion of choledochal cyst?
There will be a dilated CBD without any dilatation of the IHBRD.
Yes, that is one. That is one. So
and
these dilation may be of different types. These dilation in the ultrasound may be of different types.
Have different types.
That can give a lead. Yeah.
So either it can be a fusive. Yes, sir.
Yes. And you don't find any evidence of distal obstruction or stone.
Yes, sir. Yes, sir.
Okay. So if I give you the ultrasound finding was a gross dilation of the extrahepatic biliary tree with fusiform dilatation. IHB are not dilated. No stones seen either in the gallbladder or in the CBD.
Yes, sir.
They have made a query diagnosis of choledochal cyst.
Yes, sir.
What should be next?
It is a type 1 choledochal cyst. We can confirm by doing an MRCP, which will tell us the diameter of the choledochal cyst present, and following which, since once we make the diagnosis of a choledochal cyst, we have to go for an operative intervention of cholecystectomy and resection of the choledochal cyst, followed by a BU entry.
Wait. Now you are diagnosis of MRCY a choledochal cyst. Type 1 choledochal cyst.
Yes, sir. Yes, sir.
Okay. Dr. Basu.
See, Anuradha, what is the etiology of choledochal cyst?
It has a congenital etiology has been proposed, where there is some deficiency in the ampulla of Vater, the sphincter of OD, due to which there is reflux of the pancreatic juice into the bile duct in the developmental embryonic phase, due to which there is weakness in the biliary duct, leading to dilatations.
No. Neonatal pancreatic parenchyma doesn't produce much enzyme, so that there is no reflux in neonatal period. Okay.
Yes, sir.
So this is the type. There are many theories. One theory like this, another theory is abnormal biliopancreatic junctions. These are the theories, but only proposed one which are accepted by like a Hirschsprung disease, like achalasia cardia. So there is dearth of ganglionic cells in the distal CVD, so the proximal one is dilated. It is only for type 1 to type 4. And type 5 is different, the different etiology. There's a ductal plate malformation. So this is the proposed. Nobody can prove what is the exact etiology of this thing. What is that abnormal biliopancreatic junction?
You say some abdominal ampulla. What is that? This is the situation.
This is the situation.
So the common duct. The common
Where
duct
does the pancreatic duct ends? Where does the pancreatic duct ends? Where does the pancreatic duct joins the bile duct. Normally it joins in the ampulla.
Yes, sir.
What happens in patient with choledochal cyst? That you need to take care of.
It joins
during surgery
proximal to the ampulla.
Yes. So pancreatic juice is directly delivered in the distal bile duct.
It's not through the sphincter. Yes.
Yes, sir.
Yeah.
That is why this reflux. Yes.
Yeah. So there is an explanation saying that this pancreatic juice directly in the bile duct may be activated and lead to weakening and thinning of the duct. That is not established yet. The explanation. Okay.
Okay. So what are the types?
Sir, choledochal cyst, there are 5 types total. Type 1 is the solitary extrahepatic cyst, which is a fusiform dilatation in the form of fusiform dilatation. Type 2 is a extrahepatic diverticulum.
Type 1 has also
type 1 is subgroup.
Subgroup.
ABC.
Sir, saccular
ABC.
and fusiform.
C?
C.
ABC. A is uniform dilatation. A is uniform dilatation. B is segmental dilatation. And C is fusiform dilatation. This is the 3. A, B, C. Okay? So A and C almost same.
Yes, sir.
B and 2.
2 is extrahepatic diverticulum. Outpouching from the bile duct.
This is the very rare situation, and often people mistake double gallbladder.
Yes, sir.
Right?
Yes, sir.
3.
3 is a case of a choledococele where at the distal most part where the intrahepatic portion of the intra-duodenal portion of the CBD is dilated, called as choledococele. Hello, sir.
4.
Yes.
4 is divided into 2, 4A and 4B. 4A is where both intra and extrahepatic biliary radicals are dilated.
So
And
remember here for ultrasonography scan, you can have extrahepatic and intrahepatic dilatation. Usually, when choledochal cyst we diagnose common varieties, usually intrahepatic biliary dilatation was not there, but here you can have this.
Yes, sir.
Yes. And B,
sir, 4B is 4B is only multiple extrahepatic dilatations are there. And 5 is only multiple intrahepatic dilatations are there, which is also known as Caroli disease.
Intrahepatic, segmental or full? Segmental, maybe segmental.
Okay. Segmental or total.
And can you tell us what is Caroli disease and what is Caroli syndrome?
Sir, Caroli disease is the type 5 choledochal cyst.
Yes.
And Caroli, sir, I'm not sure about Caroli syndrome.
Okay. Why we bother to do as early as possible removal of choledochal cyst?
Because it has a malignant potential.
No. In children, why we say that this as early as possible, within a month, you have to remove the choledochal cyst.
Associated with biliary atresia.
Yes, and hepatic fibrosis. To prevent hepatic fibrosis, this is done. And when the Caroli disease is associated with hepatic fibrosis, it is called Caroli syndrome. Okay?
Yes, sir.
So, what are the other investigations that can diagnose this thing? MRCP is gold standard, I admit.
Yes, sir.
What are the other
apart from that, endoscopic ultrasound can also help in diagnosis.
When this MRCP has not in here in the market, we did other investigations. He does scan. Yes, he doesn't. He does scan. He does scan also can detect this thing.
And also
Yes,
ERCP, although invasive, ERCP is
Yes.
also a mode of
Modality.
investigation.
Modality. Is even
Yeah.
even reconstructed CT scan also.
Yeah.
yes, sir.
Indo-US, yes. Agree. Indo-US.
So how will you prepare this patient for surgery, Anuradha? How will you prepare this patient for surgery?
Sir, preparation after doing the diagnostic investigations, we have to do other investigations for pre-anesthetic checkup. After attaining pre-anesthetic fitness, we have to, since it is an anastomosis, we have to normalize the bilirubin.
So you have to keep in mind the diagnostic investigations, and you have some parameters which will be taken care of, like
the serum protein and albumin level should be optimum. Apart from that,
that is one. What else?
His bilirubin level should be high, and the CBT diameter should be high enough so that the anastomosis.
You said mild icterus, so don't expect that this patient will have very high bilirubin. Clinically said mild icterus.
Yes.
Because jaundice is fluctuating.
Yes.
You said no pallor, but hemoglobin may be low.
Yes,
you have to take care of that also. He have said he has nutritionally preserved. So if patient has low albumin, it is not only correcting, it's not correcting albumin only. Suppose patient has low albumin, how will you take care?
We have to start. We have to start high protein diet weeks before surgery on an outdoor basis, and to correct the albumin serum protein levels.
So what is your optimum protein level, albumin level?
More than 2.5 gram per dl.
More than 2.5 only. I'll refuse to
quite low. Quite low. It should be.
What is the normal level?
2.5 to 5.
No.
Sorry, 3.5 to 5, sir.
3.5 to 5. Yes.
Yes, sir.
It is good to have 3.5, but at best 3 is a bare minimum that you should opt for. Okay. So these are the patient who has got features of jaundice or diagnosis of choledochal cyst. The patient may have biliary sepsis.
Yes.
Do you need any preparation on that front?
So if the patient is coming with recurrent episodes of cholangitis, then we have to treat the cholangitis by giving IV antibiotics. And if the patient presents with hemodynamic instability, then we have to resuscitate the patient, keep the patient in
This is a patient. No. Don't go to theoretical part. This is a patient who you have examined. He is now nutritionally preserved. He has got normal blood pressure. And you are planning to do a bilioenteric bypass on the background of a diagnosis of choledochal cyst. Would you consider giving the patient pre-op antibiotic?
No, sir.
How to diagnose that patient having cholangitis but not overtly symptomatic? You have done investigation. Tell me first the LFT. What is the indication in LFT where we can suspect patient may have cholangitis?
If the total serum bilirubin is very high,
no. Not necessary. Not necessary.
Unless obstructed, it will not be very high. Very elevation.
Along with your ALP, the other two enzymes also will be raised. One indication. Another thing is you have done total count. So if there is leukocytosis, so these are the parameter of infections.
And people will do CRP again.
Okay. And CRP
also marker infection.
CRP, yes. CRP.
Yes.
Okay.
So
find
that when there is ALP raised along with other, don't think that is a viral hepatitis. It should be like if a patient having cholangitis or not. If there is with other conjugated hyperbilirubinemia.
Oh, yes, sir.
Okay, what about the patient having jaundice and doing surgery for a biliary bypass may develop post-renal failure? Why? May develop post-renal failure. If you are not preparing the patient properly. Is there a chance?
Yes, sir.
Why? What is the mechanism?
Hepatorenal syndrome.
Why this happens?
Because the renal perfusion, if the patient is not having not hemodynamically stable, and if there is having low hypotension, then that can lead to decrease in renal perfusion, and that can secondarily cause.
There are two factors. One factor is volume deficit. The other patient who are chronically dehydrated, number one, and the other patient who are prone to negative sepsis. Okay. Yes, so these are the two factors one should take care in the pre-op period. So these patients should be given prophylactic pre-op broad-spectrum antibiotics, and you should ensure that patient is adequately hydrated. How will you assess a patient is adequately hydrated before you take the patient for surgery? What are the ways to assess?
We have to see for clinical signs of.
Yes.
So we have to see for clinical signs of dehydration if they are present or not, like skin turgor, whether the skin pinch is subsiding in more than 2 seconds or not.
Then look at the oral mucosa.
Oral mucosa.
Look at the oral mucosa. Look at the eyes.
Yes,
sunken eyes, and increased thirst.
The most important?
Thirst.
Objective assessment. Objective assessment. Thirst is the most important. Objective assessment is by what? These are all subjective. You talked of. Objective is by
thirst, sir.
No, objective.
Objective.
You assess. You know it. You are doing regularly.
You know it. Yes. Catheter.
Okay, sir.
Urine
output. Yes, sir.
Yes.
BP and urine output monitoring.
When you are happy that patient is adequately hydrated, you are happy. Yes, patient is adequately hydrated.
If the patient is having more than 0.5 ml per kg per hour of urine output,
safely 1 ml per kg per hour is the optimal urine output. When you are happy with the urine output, 0.5 ml, I agree, is a acceptable output. But if you have 1 ml per kg per hour, that is the optimal urine output. You are happy that patient is adequately hydrated. So these are the few things. Yes, okay. If the PT is prolonged, how are you going to address that? Patient has got recurrent jaundice. If PT is prolonged, how are you going to address the issue?
If is prolonged, that might indicate. We have to supplement by injection vitamin K, 10 mg IM for 3 days, intramuscular for 3 days, followed by a repeat INR, PT INR, and
okay.
If it corrects, then
okay. But something about the part.
Yes, sir.
No, Dr. Basu will ask some deep part.
No, it's going good, step by step.
Yeah.
So when you cannot correct with vitamin K supplement, how to correct the P time?
Sir, we can give 2 trials of vitamin K injections, and even after that, if it's not corrected, then we can go for fresh frozen plasma or cryoprecipitate.
Where from you get the 2 trials?
2
trials means?
First of all, we'll give first 3 days we'll give and we'll repeat the INR. And next 3 days also we can give.
Not 3 days.
Maximum 3 to 5 days.
Yeah.
If not correctable, then we go for this thing, fresh frozen plasma. Right.
Yeah.
Yes, sir.
What is your optimum P time that you can safely go ahead with surgery?
INR is 12 to 16 seconds.
INR is not 16.
INR is not seconds.
INR is expressed in as a value.
Yes.
Value.
12 to 16, sir. 12 to 16.
This is variable, lab to lab. This is variable. You say the
INR 1, 1.5, 2. How are you happy go for surgery.
That is your P time. P time is your seconds.
P
That is
time
variable
12 to
lab to
16
lab.
seconds.
INR.
Yes, sir. INR less
INR
than
is the
1.5
internal. Yes.
normalized ratio.
International
1.5
normalized
that.
ratio.
Yes, sir.
Yeah.
Less than 1.5, we can go for surgery.
Less than 1.5. Yes. Accepted. So what is your procedure?
Sir, in this patient, since he's having choledochal cyst, we have to go for cholecystectomy and excision of the choledochal cyst, followed by a bilioenteric anastomosis in the form of hepatocytostomy.
Hepaticojejunostomy, Roux-en-Y.
Roux-en-Y hepatocytostomy.
Roux-en-Y hepaticojejunostomy. Do you need access loop?
No, sir.
What is access loop? First of all, what is access loop?
Yes.
What do you mean by an access loop? Have you seen? Have you seen access loop being done for some reason?
I think she has not seen.
No,
Very
sir,
rarely
no, sir.
done.
Yeah.
No, sir.
So access loop is done in some situation where you need further investigation interventions after the bilioenteric bypass. Can you name one such situation? That patient can come back with the same
for
disease?
a cutaneous,
No.
if a stoma is required, then an access loop can be.
No. Sir is asking different thing.
You have done surgery for a biliary tract disease, or you have done a biliary procedure and you did a hepaticojejunostomy for a condition, but that condition can recur afterwards. And you need to intervene into the biliary tree. What are these conditions? Name one condition. We find some patients.
If there is a stricture at the site of hepaticojejunostomy, or if there is a malignancy.
Not malignancy. If it's a patient, access loop will not help you. These are the patient who has got primary CVD stone, where there is intrahepatic stones. These are the patient who form stones after surgery. In that case, suppose you have done hepaticojejunostomy and end of this loop is brought to the stomach and did a gastrojejunostomy there. So from the stomach, you can go through this loop and then go to the anastomotic site. If there is a stricture, you can dilate that. If there is a recurrent stone, you can pass a basket and remove those. So that is a...
We usually do access loop not routinely, but when we do type 4 choledochal cyst, it is very much prone to develop stricture and stones. So if there is access loop, you can have addressed this issue later on. And many people nowadays doing choledochoduodenostomy. What is the disadvantage?
Pediatric people, even pediatric people are in favor of doing choledochoduodenostomy. What is the point in favor of doing a choledochoduodenostomy and some point against?
Choledochoduodenostomy will predispose more to Sump syndrome.
Sump syndrome.
Sump syndrome is a critical positive. Sump syndrome does not occur more often. But what pediatric people are saying that they are happy with the choledochoduodenostomy. They say that this is more physiological to deliver the bile into the duodenum.
Answer, no need of access loop. No need of access loop for further assistance.
Yes, sir.
A lot of pediatric surgery reports are coming that they are happy with, but in adult, you are accustomed to do a jejunostomy. Some syndrome is not a very common phenomenon coming up.
Actually, sir, some syndrome, when there's intact CVD, there may be some possibility. But here, hepaticodocoduodenostomy. So, some syndrome is rare here.
Yeah.
Number one. Number two, what is the against point against the hepaticoduodenostomy? Because many people are nowadays doing this.
Sir, actually, ascending cholangitis can occur easily since the sphincter function is not there.
Yes, ascending cholangitis, one thing. Another, rarely more risk of gastric cancer and biliary cancer. This is also written in something, some paper.
Yeah.
But people are doing it regularly.
Okay. Anuradha, what is Lily's modification for this surgery? Lily's modification for choledochal cyst surgery?
Oh, what's that?
Lily's modification.
Sir, I'm not sure. Sir.
You have to read it. Suppose you are doing surgery.
Hello, sir.
The choledochal, you cannot dissect the cyst from the portal structures like portal vein and the hepatic artery around. What to do?
Yeah, okay.
Because of recurrent choledochal, the cyst is.
Sir, I'm not sure.
Okay, so that is what Lily's modification is. If you have recurrent choledochal, you try to dissect the whole cyst out, you may injure the portal.
Hello, sir.
Sir, you are not audible.
Oh.
Sir, you are not audible.
Hello? Not audible?
No.
Oh. What happened? Hello?
Very faintly audible.
Oh. I'm in the same place. Hello?
Now, okay. Now,
Yes,
okay.
sir.
Again gone.
Am I audible?
Yes, sir.
Yes, sir.
Dr. Basu, please answer.
This is the situation when there is due to recurrent fibrosis or recurrent cholangitis, the posterior wall of the choledochal cyst you cannot separate from the portal structures. Then you keep the structure, posterior wall, and remove as much as possible the choledochal cyst. This is called Lily's procedure. This is rather this thing, the bailout surgery type. That is the Lily's procedure.
Why not do a cystojejunostomy? Another? A lot of people.
So actually, there is already a weakness in the wall of the CBD of the cyst, and moreover, the cyst mucosal lining that also predisposes to cholangiocarcinoma. So resection is a better option rather than doing a cystojejunostomy.
Yes. It's a development condition. If you get a cyst, especially
Sir, it's not audible, sir.
No, not audible. Should we end the class then? Okay, Anuradha.
Yes, sir.
You next time you prepare better. I think you will prepare better. And today we are closing the class as Dr. Shah has left and cannot be connected. Okay.
Okay, sir.
Yes. Am I audible? Am I audible, Dr. Basu? Dr. can conclude. Hello. Hello.
Hello, sir.
Yes, yes.
Yeah, you are audible, sir.
Yes, yes. So I didn't follow the last question.
No, sir. Actually, Vasu sir, he was there. He said that since you are not audible, to conclude the class, he was saying.
Okay, okay.
That is the last conversation that happened.
Okay, what may be the post-op complications, Anuradha? What may be the post-op complications following the surgery? You have done
there can be immediate
what may be the complications?
Bypass. Sir, cholangitis can be there. Ascending cholangitis can be there, sir. And
immediate post-op complications? Immediate post-op complications?
Immediate pulmonary complications can be there. On post-op day 1, there can be atelectasis, which can progress to...
One is general complications, pulmonary, cardiac,
yes,
deep vein thrombosis, that is one. Second is if you go to the specific complications.
Specific complications that can be anastomotic leak.
First is bleeding.
And bleeding anastomotic leak.
Here the patient who has got may have some progression with patient of bleeding, number one. Number two is anastomotic leak. How will you diagnose anastomotic leak in the post-op period?
In the immediate post-op period, the patient will have certain clinical symptoms through which we can diagnose. First of all, they can have, initially they can present with tachycardia and some abdominal pain, vague upper abdominal pain, increased guarding tenderness. They can further go for hypotension, raised counts in spite of antibiotic coverage.
If you have an anastomotic leak in immediate post-op period, this leak can be either a control leak, two things. It can be either a control leak or it can be a leak which is causing generalized biliary peritonitis. The management will vary.
Yes, sir.
If you have a control leak, that means that there is a leakage and that leak is draining outside to the drain. So patient may have localized pain.
Yes, sir.
And you find there is increased drain output. You may not find alteration of his vital parameters, maybe normally maintaining blood pressure. There is no generalized guarding and rigidity. That is one situation. Second is there is major leakage and patient has symptoms of generalized biliary peritonitis with features of shock. So what is the management for such leak? If it is a control leak, what will you do? If it is a generalized,
leak.
Yes.
Control leak, we can go for non-operative management. We can observe the patient
So
closely.
Control leak, most of these leaks subsides. Most of the leak subsides. If it is a leak with generalized biliary peritonitis, you need to take some measures like
if the patient is developing peritonitis, then we have to closely monitor the patient and take up the patient for
yes, that means
whether the
you see that depends all on the period at what time this is happening. If this generalized biliary is happening in the first post-op day, that means next morning you are finding these the features. That means there is a technical failure. There is a technical failure of the anastomosis. In that case, your drain is not functioning properly, so the bile is leaking to the peritoneal cavity. You cannot keep waiting. You have to do immediate intervention, do a good peritoneal lavage, and put drain. And then if you have a technical failure in the first post-op day, there is a role for putting more sutures. But if it is happening after 4 or 5 days, this area suture will not hold. So you have to just do a lavage and drain the peritoneal cavity. Okay. So that is how you manage. Dr. Bosak, any comment? Dr. Bosak? Okay, Honorada, is good. But what I'm trying to emphasize is in history of present illness, spend more time and go to the whole of GI symptoms, other symptoms should come in the history of present illness. Okay, so don't end up with just a few lines in general history of present illness. Okay. Thank you, Honorada.
Hello, sir.
Yeah, thank you. We can.
Oh, okay, sir. Okay, sir. Thank you, sir. Thank you so much, sir.
Somebody asks if you leak after 4 days. 4 days again is a 3 days. At the end of 4 days, it is unlikely to hold sutures because the margin become friable. In that case, drainage is there. No issue.